Ruchika, uh, anterior segment surgeon at our institute.
So just to correct you, this was published in JRS, Journal of Refractive Surgery, not Journal of Cataract Refractive.
Yeah, JRS.
So before going into the discussion, I would like to give you a brief overview of the risk factors which cause post-laser ectasia and utility of SMILE extra in preventing it. So with the advances in refractive surgery, as we know, over the past few decades, we have evolved into performing a less invasive laser procedure like SMILE. Unlike PRK and SMILE here, in SMILE, unlike PRK and LASIK, in SMILE we generally remove the tissue, a small piece of corneal tissue called lenticule. In LASIK and PRK, we do a tissue ablation in the cornea cause corneal reshaping, thereby correcting the refractive error of the patient. And also in SMILE, we create only 3 to 3.5 mm incision in the cornea, unlike LASIK, which creates a flap of 20 mm circumference. So this allows SMILE to have more biomechanical stability after surgery and less disturbance to the corneal nerves when compared to LASIK. And also, SMILE is a more tissue-saving procedure because of the fact that it takes less tissue per diopter of correction, that is about 13 microns. Whereas 17 microns is ablated.
Can you just hold it here, Dr. Tulsi? Dr. Sheetal, because this particular thing that Dr. Tulsi just mentioned and Dr. Ruchika also, per diopter.
I think it is more.
Yes. So even my
takes more tissue.
Exactly, because it takes that minimum lenticule thickness, which is always to be added to any small. That's why when you're doing a very small correction, you tend to add tissue of almost 25 or 30 microns, whereas for high corrections, you go like down to 10, 15 microns. But per diopter, I think SMILE is not as tissue saving as LASIK. LASIK, I think you do 12 to 13 microns for a 6 millimeter optical zone, whereas SMILE tends to take a little more than that, right?
15, around 15.
Right.
Yeah.
Okay. So the pathophysiology behind iatrogenic ectasia, that is a weakening of the cornea after laser refractive procedures, or mainly tissue subtraction, which happens in all the three procedures, but vertical flap cut, which happens only in LASIK, and the delamination cuts, delamination lenticule cuts, which occurs in while extracting lenticule in SMILE procedure, and damage to the Bowman's membrane happens in PRK while scraping the epithelium while doing surface epithelium removal. So all these mechanisms, they lead to biomechanical instability, and they are believed to be known mechanisms of ectasia development after these refractive procedures. Among all these three procedures, SMILE is considered to be biomechanically stable when compared to LASIK and PRK based on this pathophysiology. However, corneal ectasia after this refractive procedures was shown to occur even after SMILE with the following risk factors in the patients, which are patients who are very young and high refractive errors and suspicious or borderline topography like thin pachymetry and asymmetric bow tie as shown here. And skewing of the radial axis and also having a posterior float elevation. Other risk factors are having family history of ectasia, eye rubbing, and hormonal imbalances and systemic imbalances, systemic illnesses also contribute to the risk of iatrogenic ectasia. So there are various risk scoring systems and indices which identifies corneas at risk. One of it is Randleman risk scoring system, which considers the following criteria, as I mentioned earlier, that is topography pattern and age, corneal thickness, and amount of error, that is a manifest refraction, and residual stromal bed thickness after refractive surgery. So based on this criteria, if the score is around 3 or more, according to Randleman risk scoring system, the corneas are considered to be at risk, and generally one doesn't proceed to do a refractive surgery without doing a CXL in these patients. So this is a simplified algorithm which is published by Dr. Cheetal et al. Itself to help us in decision making for corneas with risk factors of 2 or more, as seen here. A patient with age less than 30 years and having a spherical equivalent of more than 6 diopters, and having suspicious topography, as I mentioned, inferior steepening, thin pachymetry, asymmetric bow tie, and having posterior elevation in the posterior float, and residual stromal bed thickness of around 250 to 280 microns, and Bellin Ambrosio display having a D value of more than 1.65. CBI and TBI or Corvis data, which if it is more than 0.5 and more than 0.2, are considered to be risk factors for ectasia, and other contributory history like having eye allergy and family history. All these factors, they help us to decide to give corneal collagen cross-linking as an adjuvant procedure to PRK or LASIK. So I would like to give you a brief idea about the standard CXL2. CXL is generally done in keratoconus ectasia patients. It involves application of riboflavin in the cornea under UV illumination. This procedure, it causes photochemical reaction that cross-links the cornea called as a photopolymerization, thereby strengthening it. And so here in standard CXL, we give an UV exposure of with a power of 3 millivolts per centimeter square for 30 minutes. Another variation of it is accelerated CXL, wherein we give a variation in energy dose and duration of duration is varied according to the Bunsen's-Roscoe law. This law, it states that the biological effect of CXL, it remains the same as far as the total energy remains constant. So playing with the amount of energy and duration, keeping the total energy constant, we can derive a lot of protocols in accelerated CXL as seen. So this brings us to adjuvant procedure extra, SMILE extra, which involves simultaneous high energy or high fluence cross-linking of the cornea, which is done in addition to the normal refractive procedures to strengthen the weakening effects of the refractive surgery. So this is an in-house video which shows a SMILE extra procedure. I would like to fast forward it. Yeah, from me. So which is done in our center. Basically, a SMILE extra is derived from a procedure done by Canelopoulos, who initially used CXL in femtosecond laser created corneal pocket in early keratoconus. Similarly, in SMILE extra, 0.25% of riboflavin is in saline. It is injected into the interface after the standard SMILE procedure. And it is allowed to diffuse for 60 seconds, after which it is rinsed off with a balanced salt solution, followed by UV air irradiation through the cap using 45 millivolts per centimeter square for 90 seconds, delivering a total energy of 3.4 joules per centimeter square. So with this background knowledge, let's begin with the actual journal article discussion for today. So this publication, aim of this article is to study the overall incidence of ectasia after SMILE from a high volume center, Netradama Super Speciality Hospital, Bangalore in India. It also compares the incidence of ectasia in eyes with normal and borderline topography, which has undergone SMILE and SMILE extra. This is a retrospective interventional study in which all eyes undergoing SMILE or SMILE extra for correct myopia and myopic astigmatism were studied from a period between November 2012 to August 2019, were entirely reviewed for topography and treatment planning like SMILE and SMILE extra were done in them. So the eyes were categorized as normal and borderline based on the following criteria, as I described earlier in the protocol for decision making in at-risk corneas. So here in the study, out of 7,024 eyes analyzed, 6,025 eyes were normal and they're suitable for standard SMILE procedures. And whereas 999 eyes were borderline, out of which 594 eyes they underwent SMILE and 405 eyes underwent SMILE extra. All normal and borderline eyes were followed up for 1 year. The eyes which are followed up for 1 year were included in the study. And all the procedures, SMILE and SMILE extra, were performed by 2 experienced surgeons following a standard parameters using Visumax femtosecond laser machine.
So although the minimum follow-up was 12 months, that was one of the inclusion criteria. The longest follow-up was up to 7 years also for some of the eyes. Okay, so in one of the tables, I've actually shown the average follow-ups also of all the groups, which is much more than 12 months.
How much is the average follow-up approximately? Like,
table, if you have shown that table somewhere, table A table, first table. So I've made 3 groups in that. So one group is the normal eyes that underwent SMILE. One group is borderline eyes that underwent SMILE, and the other one is borderline eyes that underwent SMILE extra. So
it is there in the next.
Yeah.
Okay.
Yeah. So the protocol which was followed at this in the study was they used 0.22% of riboflavin if Vibex extra machine was used, or 0.23% riboflavin if Peshke machine was used, and was allowed to diffuse for 60 seconds, followed by irrigation of the interface with DSS and UVA exposure through the cap using a power of 45 millivolts per centimeter square for 75 seconds, delivering a total energy of 3.4 joules per centimeter square. So the statistical analysis was done using independent tests, and data was analyzed by 2x2 contingency tables. So the results were analyzed and represented in table format clearly. This is a table from article which shows year-wise breakdown of all eyes treated with SMILE and SMILE extra during the study period.
Here you can see the mean follow-up.
Yes, ma'am.
So for the normal eyes, yeah, it was 28.9 months. And for the borderline eyes that underwent SMILE was 30 months almost. And the SMILE extra eyes was 26 months. So this was the average follow-up.
Towards the end, the numbers of SMILE extra went up quite significantly.
Yeah, you can.
You've learned along the way that it's protective, right?
Yes. It's very clearly seen.
What percentage of SMILE extra is there today? Like today in your practice, what percentage is SMILE extra?
Yeah, so anywhere between 5 to 10%.
Okay. And the criteria you're using are
the same that we have published. Right. So a minimum of 2 or 3 criteria if the patient satisfies. Because sometimes, for me, even though I have not published this, the sex also, if it's a female patient, I do consider that also as a risk factor, an additional risk factor.
Is there a distribution of the number of patients who developed ectasia amongst your patients, and is there a predilection for females over males in this kind of data, Doctor?
No, I think in this data we have almost equal number of males and females because we had 10 eyes that developed ectasia. So none of the patients in this data had any history of pregnancy or anything like that happening, but they were all borderline eyes. Only 2 eyes were normal. And that patient had a positive history of eye rubbing, very clear history of eye rubbing.
Perfect. Let's go. Yes, Dr. Tulsi.
Okay, so 10 eyes out of the total eyes in this table developed ectasia. So out of which 8 were borderline or at-risk eyes and 2 were normal eyes. So the results were clearly, I mean, it shows that 8 eyes, the borderline eyes, they developed ectasia, and the eyes, borderline eyes, which were treated with Smile Extra, didn't show any evidence of ectasia. So the results of the study was it stated that the incidence of ectasia after Smile was 0.15%, and the total number of borderline eyes in the complete data set was 999 out of 7024, which comes down to 14.22%. And incidence of ectasia and borderline eyes, who had Smile had incidence of 0.8%. Whereas Smile Extra eyes didn't have any ectasia. So in borderline eyes who had got Smile surgery were taken up for Pocket CXL and Pocket CXL along with Philly.
Dr. Sheetal, how easy is it to open the Smile pocket after a few years? Is it as easy as lifting a flap, or
You can always open it. One of the patient who was like almost 4 years post procedure, it was fairly easy. You just have to use your the Sinsky side of the dissector to scratch the epithelium over the incision, and then you just enter and use a dissector. It is fairly easy actually.
So out of the 10 eyes, 6 eyes were treated with PCXL, that is Pocket CXL, and the remaining 4 eyes were combined with Philly and CXL. Philly is nothing but femtosecond laser intrastomal reticule implantation along with Pocket CXL. So eyes with early ectasia had only PCXL, and eyes with advanced ectasia had PCXL combined with Philly. So there are 3 other studies done on Smile Extra with different protocols followed as seen here. So Ganesh et al. They followed 45 milliwatts per centimeter square of energy with 75 seconds duration. In NG et al., 18 milliwatts per centimeter square was followed for 45 seconds, and in Osman et al., 18 milliwatts per centimeter square for 3 minutes, with a total energy of 3.4 in Ganesh et al., and 0.8 joules in NG et al., and 3.4 joules in Osman et al. So
There are
these
different protocols people are using. The very first one is our protocol, which we are still continuing. So the first ours was the first publication on Smile Extra in 2015. After that, different researchers started. But then what we feel is that the protocol that we are using actually is working well, because now we have evidence also. None of the eyes have developed ectasia in this group. Whereas if you see the second one, the NG et al., their overall energy is just 0.8 joules. Now you're not really sure whether, this is very little energy actually, whether it's doing anything to the cornea or not. I'm not very
I
sure.
was wondering, because the difference is so much, like
Yeah.
0.8 is very small.
Yeah, because we thought that for keratoconus therapeutic dose, what we use is 5.4. So it has to be at least half or slightly more than that. So we derived on this protocol, and initially we started doing this, and we didn't see any significant haze or drop in vision or any stabilization was also good. No infections, nothing like that actually. And so we continued with this, and we've never changed this protocol somehow. But different people are using different protocols. So we need
I think this group from Hong Kong, which, I mean, the reason why they had used the low energy was because they had noted some haze in some of the patients. So they just
See, you will definitely have very slight haze. Okay, now you have also started doing in your center. You will also see at some point of time, like around 2 months, 3 months, or maybe as early as 1 month, a very slight haze, which is visually not significant. I have pictures of this haze, uh, but patients are seeing 6/5 and not complaining at all. Okay, the OSI does increase slightly. If you look at the scatter value, it definitely is slightly higher compared to a normal smile patient, but it really does not affect the vision, the uncorrected vision as well as the best corrected vision.
and possibly this haze regresses over time also, like
Yes. So
possibly
it's
noted in the
initially, it's
initial
very,
few
yeah,
months,
just
and
for,
then over time it comes down.
yes, couple of months. It's just like a mild form of your cross-linking haze, but of course it's not as dense as the haze that you see post cross-linking, which you have done using the Dresden protocol. Because when you remove epithelium, you definitely will have more haze. We are not removing epithelium here. We are giving less amount of energy. So the haze also is less. But if you do not see haze, then you are not sure whether your Smile Extra is working or not.
So here I had a question about two things. One was that is the epithelial healing response in the early days, is it different from the usual? Have you noticed any differences in the epithelium healing? I mean, not the healing, but the epithelium.
Yeah, it's very interesting. Actually, I am collecting data on this already. I've given this project to one of my fellows because we have a lot of Smile and Smile Extra data. So I'm comparing everything. The biomechanics, the epithelial response, the optical quality, objective scatter index. I need to analyze this and be, back with the more definite answers on this. But definitely, it is not more than Smile. So generally, what we have seen is I've published a paper on epithelial response after Smile. This was in 2017 in JRS, and we saw that on an average, you have around 5 microns thickening.
Okay.
Yeah, but that of course varies depending upon the amount of myopia corrected. But on an average, you will definitely see in the mean thickness value an increase in 5 microns.
Why I'm asking this question is that today we had a follow-up for one of our Smile Extra patients who was done just about a week back.
Okay.
And on day one was plano and 6/6 in both eyes.
Okay.
And today that patient came up with one eye showing a -1 with a vision of just about 6/18, 6/12, and with epithelial hyperplasia in that eye, but not in the other eye.
And the other eye was what? Only
both
Smile.
eyes were Smile Extra,
Both eyes were
but
Smile.
both eyes were on day one plano and 6/6, and we were very happy because the outer ear, everything was
No.
like perfect.
Actually, if the patient on first day is very, you see a zero is actually not a good thing,
Actually,
because with the Smile Extra, you are washing the interface definitely. See, with Smile, many times we do not. We have stopped washing the interface completely now with Smile. So the day one autoref results may be more reliable, but with Extra, we end up doing a lot of interface wash. So first day autoref should not be considered actually.
So we are going to follow up. And our other patients that we've done over the last 2 years, they were, kind of stable, and they never had any significant difference from our Smile patients. But this one in the early, like 1 week only was, so I thought I'll ask you. So let's go on. Yeah.
Two studies in this table, they've quoted that visual acuity more or less remained stable in almost all eyes who underwent Smile Extra, and there were no complications reported such as keratitis, ectasia, or regression. And two studies, they stated that they observed that high safety index was seen with Smile Extra 1.29 in these two studies. But NG et al. Studies concluded that Smile Extra is an overall safe procedure. However, the safety index was slightly lower than the Smile alone. Smile Extra had 0.96 safety index and Smile had 1. There are currently 12 long-term studies in the literature on LASIK extra, of which 9 were conducted for myopia and 3 for hyperopia. For myopia, all studies uh, they reported either similar or better long-term results, refractive results, refraction and efficacy index, and uncorrected distance visual acuity with LASIK extra better than the SMILE alone. The few more studies done for PRK extra and PRK2, and these studies found that PRK extra has similar or better results as compared to PRK alone in terms of refractive outcomes. Although visual acuity, uncorrected visual acuity was better in PRK extra group in early post-op follow-up, like around 1 month. But there was a significant difference in at 1 year post-op. This could be due to post-op corneal haze, which was significantly higher in PRK extra when compared to PRK alone. So our present study also depicts the preoperative and intraoperative parameters clearly in tabular formats, and also time taken for ectasia development and management of ectatic eyes after SMILE by CXL and FILI PCXL, and maximum follow-up after management, and status of the fellow eye was also clearly defined by tables. So in PCXL and FILI-CXL treated ectatic eyes from borderline corneas were analyzed by following parameters like visual and refractive outcomes, central corneal thickness, keratometric changes, elevation in the posterior map, and anterior chamber depth changes. So when this article is analyzed by MARI framework, which is a method to read a clinical research, we found that in the study, author the study question was well defined. It was done in a single center, and the study population was also well defined. Surgical procedures all were described in detail, and similar techniques were used in all the patients, and similar follow-ups and pre-op and post-op parameters measured were similar in all the patients. Inclusion criteria were well defined. Diagnostic and outcome parameters were also correctly defined. In the results, diagnostic parameters and outcome parameters were correctly projected in contingency tables, and incidence of ectasia, normal and borderline eyes were appropriately estimated. So in the interpretation, author says that planning cautiously, considering SMILE to be biomechanically superior when compared to LASIK, led to the error, and that would be the cause behind few eyes who went into ectasia, according to the author interpretation. So
These were basically the initially treated patients. So this at that time when SMILE was not very popular at that time, it was just recently introduced, and a lot of people said that because you're not cutting a flap, there is no vertical cut, and the cap becomes part of your residual bed thickness, right? So it may be more biomechanically stable. And there was 1 or 2 publications also by Professor Dan Reinstein where he showed that biomechanically it was better compared to PRK and LASIK. So then we thought, okay, we went on to treat some borderline eyes. Even if you see, I have given data of all the eyes, right? All the 10 eyes that had ectasia, few of them are actually form frustrated keratoconus, and 2-3 of them are actually, you can say now that this should never have been treated, right? But then at that time, sometimes you are so influenced by the papers, by a company guy who says no, it is, you try, nothing will happen, right? So basically we felt responsible when we saw this data, and then we had these cases, and we thought, no, we should share it with everyone, and make it very clear that you cannot consider SMILE as biomechanically better compared to LASIK or PRK. it is a tissue subtraction technique, and you have to be cautious, as equally cautious as you would be cautious in planning a LASIK procedure for any cornea. So that was the message which was given very clearly in this paper.
Absolutely right, Dr. Sheetal. In fact, when Smile came about, I remember there was a lot of hype, and in the international literature and everything, that you can, because you're not cutting Bowmans and you're not sacrificing and you're not making a flap, so biomechanically you are very stable. In fact, to the extent that I remember in one of the APA or APSRS meetings, I heard some papers where they were actually trying to say that, in fact, it was Cynthia Roberts who had one course which was there, where their initial studies had started showing that they were better than PRK as far as biomechanical stability. But later on, she presented the opposite data at another meeting, that PRK may be actually biomechanical. And today we know that selection case exclusion criteria for Smile are the same as that for LASIK. But at that time, it was being proposed that you can actually go a little beyond what you might go with LASIK, and as far as corneal thickness and other parameters are concerned. But so maybe at that time, that is what influenced your early cases, where you thought that you get away, but later on, within a year or two, you would have realized that the thing is, and today we, in retrospect, we can always kind of analyze that.
Yeah, because people were treating like -14, very, very high corrections, removing a lot of tissue. So I also want to give you a message here that we do not recommend Smile Extra for a power which is very high, like, for anything more than -8 or -10, because you cannot stabilize a cornea after destabilizing it too much. Like, you remove a lot of tissue, already patient has some risk factors, and then you think you can do Smile Extra and make it stable. Smile Extra may not work in every situation. So it is, you have to do a case by case selection, study every case, study the risk factors. So this is how I do. So I just read basically the topography correctly, properly. Now we have MS39 also. We just don't rely only on Pentacam, because with MS39 you get some more additional information which can actually help you identify these eyes at risk more accurately, and with more confidence you can decide your decision. So a lot has changed actually after this paper, and with all the experiences that we gained during this study.
So Dr. Sheetal, I wanted to ask you two quick questions here. One is that what contributes more to the biomechanical strength of the cornea, the cap thickness or the residual bed? Because this has always been a debate, and right? And the second,
I know.
So it's a difficult question, but I thought whatever you use. And the second is that the lenticle removal in Smile tends to, sometimes if you're doing a big correction, like maybe a -8 with a -2 cylinder or something, you'll end up removing almost 150 microns. And in my mind, I used to kind of stop with LASIK at ablation depth of just about 130, 125 at the most. So in Smile, what is your cutoff for the lenticule thickness beyond which you will not want to remove a lenticule? And what is your corneal thickness cutoff for patients, even for small? Suppose you're doing a 2-3 diopter Smile, at what is your lower pachymetry cutoff if everything else is normal? So these 2-3 things have always been a dilemma.
They are a dilemma for me also, but I can just tell you what I feel about these questions. So the first one was whether the cap or the residual bed thickness. I feel that residual bed thickness is still important, because ectasia does start from posterior surface. So you want more tissue under your delamination cut. So I have no hesitations in making a cap slightly thin in order to improve my residual bed. I also reduce my optical zone sometimes to as low as 5.75 also, if the pupil size is small. So I do all these adjustments. My minimum thickness also goes down to 10 microns, which is the minimum that you can plan. So I do everything to improve my RST. So this is my take on this. Second was minimum pachymetry. No, the maximum amount of ablation we are comfortable. So there's no such criteria. As long as the RST of 280 and more is satisfied, we do all corrections. And depending upon whether the patient is young, has any risk factors, and we combine it with Smile Extra. Yeah, and minimum pachymetry, 480 microns is my comfort zone. But we have also corrected. You're asking for Smile Extra or Smile only?
So smile.
Then it is 480. For with Smile Extra, we have actually treated as low as 460, 65 corneas also. But of course, they had less corrections, like 1.5, 2.
They were otherwise totally normal, right?
Otherwise, totally normal, just thin pachymetry. Yes.
But if you had even like a FFKC kind of a thing with more than 2 or 3 things, would you still proceed with Smile Extra? I mean, that is your indication.
No,
like,
no. See, if anything like FFKC is visible, we don't.
Would you then you switch to PRK Extra if at all, or
no? My choice now is Pachymetry. PRK Extra we do sometimes, but I'm not a great fan of PRK Extra because I'm really not sure about the haze component and how much it will about the refractive correction also, the stability of the results. I don't have experience, so we don't do that. So then I switch to Feki Kaiwal.
I have a question, Dr. Sheetal, not related to this article exactly, but what's your take on the use of Mitomycin in these like PRK Extra or doing a cross-linking in these patients? Because one school of thought is
I know
it's not.
Yeah, really some people think Mitomycin causes haze and something that it prevents haze. So we have always been using Mitomycin in all surface ablation cases with or without cross-linking. And if it is cross-linking, then we use for 10 seconds extra. So normally we use for 20 seconds if it's CXL with PRK, like topo-guided PRK treatments for early keratoconus. There we use it for 30 seconds. And we have not really seen any very significant haze or haze. Of course, some amount of haze always comes with due to cross-linking. But in only PRK patients, we have not seen any significant haze using MMC. So we follow this protocol. We always use MMC.
But for PRK Extra, if you do it like with topo guided and all, what protocol for what energy are you using for the cross-linking, and what like duration of what time are you using riboflavin? Are you using the same one like the Peshke L kind of a thing, which we use for Smile Extra, or?
Personally, okay, for PRK, for the topo guided treatments.
Yes, yeah, PRK Extra basically.
One is PRK Extra for prevention of ectasia. One is for keratoconus. Both are.
I understand. I mean, I know. So the protocol, your energies would be different for those for keratoconus and those for prophylactic, like PRK Extra as such.
Yes. So because we do not really do the PRK Extra for prophylaxis. So if at all I have done 1 or 2 cases, I have to refer to the literature and see what others have used. So I really don't remember that because we don't do PRK Extra at all.
Right.
Yeah. So if it's topo guided PRK, then of course our energy has to be 5.4 joules, the final energy. And in that, we prefer to use a 18 milliwatt protocol for 9 minutes or something. So this is the protocol for.
Perfect. So it's a standard protocol that accelerated, but the same total energy would be the same as a standard.
Yeah, not the 30 into 3.
I understand.
Just to save time, it's not that okay. So I just somewhere in the middle. So 18 into 9 minutes or something is the protocol.
Perfect.
And Dr. Sheetal, in your series, what was the earliest that a patient post-Smile has presented with ectasia? Like the earliest in the follow-up that you've noted that they've.
I think I've given him some table now. I don't exactly remember. Think around the mean period at which the cases presented were 21 months or something, I believe, in this. That is the mean period. But earliest, I think, was as early as after 2 or 2.5 years. None of the patients presented in the first year for sure. Or in the second year also. It was 2 years and later. On an average, 3 around 3 years.
And have you noticed between your LASIK and SMILE patient, what's the longest? I'm including LASIK also in that because, what is the latest that you have seen presentation of ectasia after LASIK or SMILE? Just a while, guys. Kind of not an.
LASIK ectasia I have not seen only in my clinic.
Wow.
In our series,
Right.
our treated patients.
Your treated patients.
Because what happened when I joined fellowship, this was in 2013, sir had already started doing SMILE. And SMILE became a most predominant, like the dominant form of refractive surgery that we were offering to our patients from that time itself. So the only LASIK patients we have seen in our institute, are the Presbyon LASIK patients. Okay. They are already above 40 and risk of ectasia is
Shri Ganesh has been doing LASIK for 20 years now. So yes. I'm sure those patients still come for follow-ups from like 10 years back and more than that. So, I saw a couple of LASIK ectasias happen 10 years after LASIK, which is quite amazing because, patients are doing fine and they suddenly developed ectasia within 6 months following eye rubbing for allergy and, for patients had other things with, eye rubbing was basically one of the main factors. So I thought that maybe if you have an idea of, long-term follow-ups.
I have otherwise seen from, patients referred by other surgeons or patients just coming to us for second opinion. As late as you said rightly, as late as up to 10 years they can present. And sometimes they will have history of pregnancy and all that. In females, that's why I should have even published this, that female sex have one more extra red flag in your mind.
So if a person comes to you for asking for a SMILE or LASIK procedure, and if it's a girl who asks you that, will pregnancy pose any risk for me, what do you say? Would you refuse surgery or do you counsel them?
No, I don't refuse surgery. If there is no other risk factor, and she's just female, of course, she also has the right to enjoy glass-free vision. And it's not that every female will have ectasia related to pregnancy, but I do counsel them clearly, and I tell them that pregnancy is a state wherein due to hormonal changes, you can have a progression of your myopia, so the number can change. I don't really say that you can have ectasia because ectasia is something that scares the patient. So I just say that your power or vision can change. Right. So that can be due to different reasons. Either it could be the progression of your number itself, or it could be some issue with the surgery that we do. So I just counsel them very
because I've had a couple of very intelligent patients ask me this, that is there a risk for undergoing LASIK or SMILE at the time of my, when I later on have a pregnancy. So then it becomes very difficult to kind of give them
some of those females who come and ask for refractive surgery who are already married. I actually, unless they are very keen, I actually ask them are you kind of planning soon or something? So then if they say yes, it might happen. So I'm like, okay, it's better that you finish and then after that you come for a refractive surgery.
That's a very good advice.
Yeah, I always kind of personally talk to them and then ask this question, because once they're married, then of course, so if they are planning, then I'm like, okay, fine, it would be better if you kind of come later, maybe 1 year after your pregnancy. So things would have settled and, things you can get better results and more stable results. So
I think let Dr. Tulsi finishes because I think Rohan is also there and a couple of other people who might want to
okay, sure. Yeah.
So Dr. Tulsi, you finishes and we'll go to the discussion. A little more discussion.
Yes, sure. So the conclusion of the study, it states that SMILE is a safe and effective, stable procedure to prevent ectasia in borderline cases. And more long-term studies are needed to recognize it as a standard treatment of care for borderline corneas, thus expanding the scope of our refractive surgery. So I would like to present a case from our setting. Who is a 28-year-old male patient who came to a clinic for laser vision correction, who had stable refraction, and there was no history of use of contact lens, and his anterior and posterior segment were normal. with a refractive error of -4 spherical and 0.75 cylindrical at 40 degrees in right eye, and -5 spherical with -1.25 cylindrical with 160 degrees axis in the left eye. So this is pre-op pentacam 4 refractive map of right eye, showing asymmetric bow tie pattern, and pachymetry is slightly to the lower side. And as bad map also shows suspicious posterior elevation points. Similarly, in his left eye, the findings were similar to the right eye, and we chose to go ahead and do a smile extra procedure in this patient. This is eye trace of patient preoperatively of right eye and left eye.
So this was an ideal case that you showed, where there was no keratoconus, a moderate refractive error, low to moderate. What was the residual bed thickness in this case? Do you remember?
I'm not sure. I
Yeah,
have to go
because
back and
I
see.
would have operated this patient. Yeah, but I think what we normally would do is that although I normally use a 120 micron cap,
Mhm.
but in such cases, I might actually make it thinner,
Yeah.
because I usually do 120 because just in case you have a suction loss, and if you decide to, kind of,
Deeper.
yes, then you can still have some room. But if I'm doing a bigger lenticle removal, then I will, or if I'm dealing with a smile extra, I might make it thinner. And in that case, I'll leave a thicker bed as much as possible. So I don't know, with the 4 diopter thing, I think we would have removed something like 18 microns or something of lenticule, and left behind something like a 300 plus bed for this patient. Yeah, I try to leave 300 plus in most often, but
Okay.
wherever possible. And then, of course, in some instances with high corrections, I may go down to like a 290 or a 280.
Okay, we actually with Smile Extra go down to as low as 260 also, 260 to 280. So our comfortable RST limit is 280 plus, and with Smile Extra 260 to 280.
So Dr. Tulsi, can you stop sharing the screen? And if anybody has any questions, we have our other doctors from the hospital as well. And Dr. Rohan, I had just sent him the link to join. And we have our other faculty also from the clinic. So I can see Saurabh is also there, Dr. Das, Amrita is there. So if anybody has any things to ask about today's, today's presentation and today's topic, although most of our other people are all retina people and technology and other specialties. So yet, so I had one more question, like the riboflavin that we use. Currently, are you guys using any transepithelial PRK or something? Because not anymore,
We
right?
don't have experience with transepithelial.
Because we did that for about a couple of years, 7-8 years back, and then we realized that it wasn't really as effective as CXL. But so anything else, Dr. Ruchika? And we have an opportunity today to learn more about Smile and.
I think I remember, Tulsi, there was one table where, ma'am, you've like most of the patients that landed up developing an ectasia, and you had to either, do a pocket CXL or with the lenticule implant in those eyes. I think there were 2 patients in which the other eye, in one you did a prophylactic CXL, but in the other one you decided to just keep a close watch. So I wanted to know what was the basis for that.
The table is not clear, ma'am, but the reference.
I think maybe the one which maybe the patient was not willing or something, because whenever we have ectasia in one eye, then generally we advise prophylactic cross-linking for other eye also, unless the vision is 6/6, there's no loss of BCVA. Must have been some reason like that. One patient you said, is it?
Yeah,
No
so there
intervention.
is one patient where there is no intervention in the other eye, but the other one underwent a prophylactic CXL. So I just
first, So this eye had Philly with the cross-linking. And status of the other eye, it's mentioned as no progression to ectasia. The case number 5. right? Case
Right.
3, yeah,
Case
5. Yeah, so other
left
eye
eye.
had no intention, and there was no progression to ectasia. So maybe because there was no patient was a local patient, patient may have agreed to
Okay.
come for follow-ups. We were able to follow up the patient. Patient did not want it, because we always have to discuss the possibility. Okay, we cannot, because if the patient's vision is 6/6, as of now there is no evidence of ectasia. We can always discuss this with patient, that we can either have a close watch or do a prophylactic. I would do prophylactic cross-linking if I cannot follow up the patient. And patient has risk factors, like many of these patients are chronic eye rubbers because they are on the system. So in Bangalore, we have a lot of IT guys, who come to us for Smile, and they are on the system for 12 hours, 8 hours, like that. So where I feel that the patient, may not be very, compliant with the with my advice, and or will not come for follow up, then there I would suggest. But probably in this patient, the vision was not affected and there was no evidence of ectasia, so we thought we'll just follow it up.
And the lenticule that was implanted, were there any specific parameters for those lenticules?
So these lenticules, we are mainly matching the spherical equivalent of the recipient eye. Okay, so it's not a very exact matching of the power, because it is not possible to have exact power matched, because some of the eyes will always have some amount of cylinder. So your patient that you're implanting can have slightly more cylinder. So mainly spherical equivalent we try to match roughly. It's not very exact and precise matching of the power. Moreover, we also have to take care of the posterior curvature changes whenever you are implanting tissue for correction of hyperopia or keratoconus. In keratoconus, of course, keratoconus or ectasia, we modify the tissue. We use a donut shaped tissue because you don't want the center to steepen further, because there's already ectasia in these cases. So you don't implant the complete tissue, the complete smile lenticule, but we use a 3 mm Trifine and refine the central part to make it a donut shape. And then we adjust it on the corneal apex. Basically, we apex on the first Purkinje image, and then we center it in the pocket, and then combine it for cross-linking. So this generally works for those ectasias where the ectasia is more central, is more axial. Where it is very decentered, like a decentered keratoconus cone or decentered ectasia, there it might not work very well, because the tissue is mainly as a filler, it's not rig. So we have to understand that the ectasia is more cornea. Okay, so it doesn't have a mechanical effect. It is more of a filler. You have a ectasia in the center, you have a peak, and then you have a flat area. So you're just elevating the flat area. So you're putting the tissue in the flat zone. So you have a relative flattening in the center, and it improves the overall shape. Okay, the overall irregularity, shape, abrasions. So we have seen amazing results in some eyes, actually very good results. I've also published a paper on smile ectasia treated using smile lenticules itself in JCRS. So there are, I think, 4 eyes published, the outcome, complete outcome with the topographies, the difference maps. You can see, I think 2-3 eyes have got really good result. So if we still need to refine this technique, we still need to have some kind of nomograms, how we can do proper matching, even at what depth it should be. Implant is not very clear at this point of time. We have limited experience in this, but we are still learning. And a lot of people actually in Europe and China are already doing a lot of tissue addition techniques for keratoconus, hyperopia, and we are also learning from their experiences.
Also, I had a thought like, how is the refractive stability, since you have a big number of smile extra eyes
Yes.
compared to your smile eyes?
Yes.
Because over a long-term follow-up, that would be another study in itself.
I have some results on this. So we, of course, have this study also going on, because we have one cohort, and on the same cohort we are doing different studies comparing smile and smile extra on different parameters. So one active stability. So unlike as people think that it may cause a hyperopic shift over time, right? This is what people say, that, oh, you're doing cross-linking, over time you may have some flattening, it may go on to hyperopia. But actually, surprisingly, it did not happen. The mean follow-up in that group is actually around 3 years now. So we have analyzed outcomes at an average of 3 years in both the groups. And what we have found is that in the smile extra group and the smile group, the average regression is not statistically significant. It was not statistically significant, although the cylinder was higher in the extra group. This is what so the average cylinder at the end of the 3-year follow-up was comparatively higher, but again, not statistically significantly higher in the extra group compared to smile. But the overall SC was similar, was comparable, and there was no significant difference. But overall SC was slightly higher again in the smile extra group, but not smile group. So we can derive different inferences from this. One could be, you never know, it could be ectasia in progression, which the smile extra is actually just delaying it. We never know that. That's why I'm saying we need a very, very long follow-up of these smile extra patients based on just 2-year, 3-year study. We cannot say that it is safe enough. Of course, we now have data of a lot of patients who are 7 years, 8 years, doing very well. And they were, of course, all borderline. But then we never know that 1 out of these or 2 out of these ends up having ectasia at a long term, very long term. And then, our understanding about this may change.
In fact, that's the time. The critical time is
Yes.
7-8 years
Yes.
after your extra procedures.
So I will
That's when-
continue working on this. I will continue to publish, because I always say this data. I always tell to my fellows, this data is gold. You people do not know. We can do so much with this data. We can continue publishing every 2 years, 3 years, and then all these long-term results.
Wonderful. So I think it's been a very interesting discussion. Anything else, Dr. Tulsi? You have any?
I would like to ask a small question, Dr. Sheetal. So did you find any difference in the number of patients or increase in the number of patients who were planned for smile extra procedures after you added Corvus ST to your armamentarium?
Definitely, because it adds one more factor to your one more factor that confuses you, I would say, rather, because when you are considering your TBI, CBI, and you have cutoffs, so sometimes you see that everything else is normal, but it's the CBI, TBIs which is in the yellow zone or red zone. For patient's sake, and especially after having so many ectasias and all, you become overcautious. So definitely, I'm sure this number which has increased in our overall smile extra procedures is also a result of the Corvus getting added to our system, because when we are considering, then we do have to consider these parameters, and then we cannot just say, okay, no,
you can't ignore it, basically.
You cannot ignore it. That's what. So you cannot ignore it. You can't just close your eyes and then say, okay, no, everything will be okay. So because you never know, and sometimes you are a bit worried because these patients are very, very, informed patients. They read internet and all that, these young patients, and sometimes because of the medical legal issues, it's so important, because I've had a few patients, actually 2 patients in my life, like after I started my refractive surgery career, who actually read my papers on smile, and they asked me before surgery things like, will you be using the Einstein dissector, what instrument you will be using, how much optical zone you'll be using, things like that. And so I was like really scared also that people these days do their homework and then come with all the information. So you have to be very cautious when you talk to them. So sometimes I see these type of over enthusiastic patients. So I'm like, okay, I do tell them, see, this particular parameter is in yellow zone for you, okay, or in red zone. I'm not saying that this is an abnormal cornea, but this comes under the category of borderline, okay, which is not neither 100% normal nor 100% abnormal, but it could be a normal variation of a normal only. But then just to be 100% sure, so that we don't have any problem in the future, we can do something as a Smile Extra. So it's just that sometimes you are so cautious, and maybe the patients are like that, that you are afraid, for future medical legal issues. You don't want hassle, you don't want complications. So like, chalo yaar, just tell them, at least inform them about Smile Extra. So I also mentioned in my plan of care that patient informed about Smile, patient can undergo Smile/Smile Extra. If the patient chooses Smile, then I always tell them to come for more follow-ups, more regular follow-ups for the at least first 3 years. I ask them to come every 6 months for a topography. That is my protocol. If the patient refuses a Smile Extra, or so anywhere where I feel patient is at risk and doesn't want Smile Extra, needs Smile Extra, then I say, okay, no Smile Extra for you. We'll just directly go for phakic IOL, right? So it is again, as I said, case to case decision making.
Has MS39 made your numbers, I mean, your doubtful eyes increase? Has it increased or decreased with the MS39?
Actually decreased, I would say. Yeah, because with MS39, you have epithelial thickness profile that helps you, the stromal elevation maps, which are very useful to, because Pentacam overdiagnoses keratoconus for sure. The bad display, bad maps are so misleading at times. You can just have those things due to contact lens, just because of steep keratometry. So having just 1 or 2 parameters in yellow or red sometimes doesn't mean that it is keratoconus. So overall bad D value is actually more important. But whenever we see on the difference map, one small yellow or one red, we are, a bit more cautious in those cases. So, but with MS39, it is much more reliable. That's what I feel. And with the stromal maps and the advanced keratoconus summary that it gives you in the end, and it also has a lot of points, notable point spread function, where it actually can see the distribution of the thinnest point, thinnest elevations, and the thinnest point of epithelium, stroma, overall thinness, but it's so many parameters. And then it shows you in a red circle, is a red circle, the yellow circle, the white circle. So if all the points are within the red circle, then for sure it is keratoconus. So you have different maps through which actually you can verify and re-verify the diagnosis. In Pentacam, it's just the chord map, the elevation, the bad, and we just get stuck. Okay, this is what it tells us. You have to believe it. In MS39, you have different things that you can look at individually. You also have epithelial abrasions separate from stromal abrasions.
Oh, epithelial aberration.
Yeah, it's very interesting concept. I love it. I'm designing some new studies on that.
Yeah, it sounds really interesting, but I've kind of, stayed off MS39 for the time being. And the Corvus, because Corvus, everybody who's using it says that our, rejection rates have gone up drastically. So, and
we just, because it gives you something additional, sometimes
it's nice. I mean, we wanted to do it, but MS39 sounds very interesting. And
MS39 is interesting, actually. It has a lot of other applications also.
Absolutely.
Yeah.
One last question from me, and then I don't know if anybody else has any. Like, since also your center was doing ICLs in the highest numbers for almost last 15, 20 years, what is your now in long-term follow-up? What is the incidence of cataract and vaults going down?
Very low incidence of cataract. That at least since I have come, I don't have a percentage, but since I've joined the institute in 2013, in our basically our operated patients itself, we have just seen very few, maybe 5 or 6 cases having cataract extraction with the explantation of the ICL, especially after V4C, since V4C has
that's
been introduced.
Some of our patients are coming back which were before the Centroflow, before this thing came up. And of late, in the last 1 year, actually, I ended up seeing about 3 of our patients who were done like 7, 8, 10 years back. who
Yes.
came up with the
Most
cataract
of these
because
are
they
those
didn't.
patients only who were operated with the B4B model.
Right. So
Yeah.
that's what was also, and many of these patients, the vault goes down over 5-10 years.
Yeah.
So that's another thing. And then you're kind of concerned that they will go on to develop a cataract.
So
But
there's another reason to buy MS39, because you can actually see the dynamic vault in this. So I've actually seen in the ICL patients, it creates a video recording. When you are measuring, you can measure vault in photopic, mesopic, and scotopic conditions. So that happens basically, there's a illuminated placido disc. So as you select the setting, the illumination changes accordingly. So actually you can see beautifully vault changing, going down in photopic condition. The most photopic condition is 40 lux or something. So you actually see, and I have myself measured, there can be a difference of up to 160 microns.
Wow.
That I have seen. And so this is really good that if you have a patient who has a low vault post-operatively, you can actually follow up and see, because this is a more realistic picture of a vault rather than taking one static measurement with the OCT.
So in fact, my OCT technician, he actually does that. He uses a torch, and he, on the OptoView that we have for the OCT for our this thing, we actually reproduce this because it does not have the option for recording the video. He actually records the videos and shows me with photopic and scotopic. Rohit has done
Very
that.
intelligent, actually.
Yeah, so
Nice.
we've actually experimented with that. Yes.
Yeah.
So I think we've had an amazing session today with a lot of information. So
Absolutely.
any final this thing, Dr. Ruchika, Dr. Tulsi, or any comment from Dr. Sheetal before we close?
Just one question, Dr. Sheetal, do you routinely, look at the corneal densitometry, like with the bad maps? I don't think anyone does, but do you?
No. Corneal densitometry for me is only for those patients where I see haze or something. Post cross-linking, some studies we are doing with
Because one of the papers, there are just 3 or 4 possibly on Smile Extra, and one of the papers has the group from Egypt has focused a lot on the corneal densitometry. That's the reason why I'm asking. Like, do you?
Well, I am also doing another study with this itself, Smile versus Smile Extra densitometry changes. Surprisingly, we found that at 3 months, the mean densitometry in the extra group is actually lower compared to only Smile. Where I thought it would be the opposite, because you're doing extra, you're activating keratocytes, there's some haze, so densitometry should increase. And I'm really seeing, surprisingly, every patient post Smile Extra, actually densitometry is less. I have to find some answer for this. Maybe, I don't know, the apoptosis that it causes, rarefication of the media. I don't know. I really need to read more about the cross-linking and its effects. But surprisingly, it is actually less with cross-linking. You also can actually see this. You also started doing Smile Extra, and just compare everything you have. You have eye trace or whatever equipment you have. Start comparing Smile versus Smile Extra in every parameter. And sometimes you can get very useful information.
Great. Thank you so much. Yeah, it was really interesting. A lot of interesting stuff to learn. Thank you so much for taking out time for us.
Thank you so much for the kind invitation. I also enjoyed the discussions.
And well presented, Dr. Tulsi. Thank you so much for working.
Thank you,
She had
Dr.
actually prepared it last this thing, and then when we postponed it, luckily it's good that it got postponed because she had a food poisoning next morning.
Oh God!
So
I hope you're fine.
Yeah, I'm doing fine now, ma'am.
He's into Dehradun from Hyderabad, so it's total change of atmosphere. Yeah.
Okay, well presented. Congratulations.
Thank you, ma'am. Your valuable knowledge to us.
Thank you so much.
Thanks everybody for joining our retina side also, because it must be really up,
Okay, let's take a picture.
So,
I'm taking
yes,
a screenshot.
Yeah.
Everyone, Smile Extra now.
Yes.
Yeah.
Right.
Send the picture to me.
I will, for sure. Thank you.
Thank
Bye-bye.
you. Good
Bye-bye.
night. Bye-bye.
Nice meeting ahead. Bye.